I wanted to touch on some of the other things we do outside of the room, and that includes CT-guided biopsies, lung biopsies of pulmonary nodules or liver lesions, or something we commonly perform every day. We have procedures like that in the department. We do a lot of breast biopsies. Obviously, one of the biggest areas of contention this last year on the news has been the whole issue of mammography. And I won't use this forum to discuss mammography at length, but I will say that screening mammograms on women 40 and over will reduce the number of women who die of breast cancer by almost 35%. And for all the problems mammography has, it does save lives. The biggest challenge is the false positive, and that's why we've really, over the last 10 years, minimized the intervention of the breast biopsy. We've gone from open surgical biopsies to very minimally invasive needle biopsies, which are done by basically a robot arm under stereotactic guidance. Patients tolerate these procedures almost universally without difficulty, and with our pathologists we get the answer back usually the next day. This is another area where I think our department has really been a good service to the community and allowed us to find many cancers in an early treatable state. Probably a good example of a problem that patients seek us out more often than they are sent to us by the referring provider is the fibroid embolization. As many of you are aware, fibroid disease is very common. Over 20% of women in their 20s have at least one fibroid. By the time you get to age 40, 40% of women will have some fibroids. Having a fibroid isn't necessarily a big problem or a bad thing, but if it's causing issues or symptoms like anemia from prolonged bleeding with menstruation, or some mass effect issues related to pressing on the bladder or constipation by placing on the rectum, these are areas where patients can have a dramatic benefit by removing the bulk symptoms of the fibroids. And increasingly popular is the procedure of fibroid embolization. And it's a procedure that we have had here at the Portsmouth Regional Hospital for probably over 10 years, with Dr. Pierce specializing in some of these gynecologic interventions. With an excellent track record. We've had this procedure done on several of our friends, family members, employees, and it's rare for us to have a person afterwards who wasn't satisfied with their results. And by and large, these patients were able to avoid hysterectomy. That doesn't mean it's a solution for every problem. There are patients who we evaluate and decide that they'd be better served by our highly skilled surgical colleagues doing a hysterectomy. But given a choice, I find that many women prefer to have themselves kept whole without losing their uterus and or ovaries. And most often we're looking at a one-day turnaround between the procedure being performed and getting home with their families. Another gynecologic procedure which we perform in this procedure in concert with our gynecologist colleagues is fertility work for the hysterosalpingogram to assess the uterine patency and the fallopian tube patency, which is a test where we actually put contrast or X-ray dye into the uterus in order to check to make sure everything's okay inside the uterine cavity and the fallopian tubes. Usually done for patients who are having trouble conceiving. And this is not an infrequently performed test. It's best done in a room like this or one of our fluoroscopic rooms where we have high quality imaging. And in certain circumstances in the past, we've been able to actually, Dr. Pierce and myself have both had experiences where we were able to take a block tube and using these same catheters and guide wires open up the tube in order to help people with future pregnancies. That's just something people need to know is out there. There are other techniques now to help with infertility as well, but it's part of the workout and one of the things we do.